My name is John Cullen, and I want to tell you a story. It's a story about a scandal, broken relationships, gossip, rumors, money, corporate rivalry, and curling. It's the story of Broomgate, how a single broom, yes, a broom, turned friends into foes and almost killed the 500-year-old sport of curling.
It was a year I'd like to forget.
Broomgate, available now.
Frequency Podcast Network. Stories that matter, podcasts that resonate.
Hey, it's Jordan. When we started asking you for your money problems, when we launched In This Economy, we knew we'd get some sad stories. We wouldn't be making this show if people weren't struggling. So I was prepared for that. What I wasn't quite ready for, though, is how many people are dealing with problems affording medical care. That's something we like to think of as an American problem. Until, of course, we need care that falls outside of the narrow Canadian definition of public health care, like a dental problem. Or until we run up against an urgent problem and a system that's simply not equipped to deal with it quickly or at all. If you or a loved one has ever struggled with mental health or with addiction, you know how all-consuming that can be. And if you've ever tried to use exclusively public health services to treat it, you've probably dealt with a lot of frustration. And in the middle of increasing mental health problems, as well as an overdose crisis already in full bloom, we had to ask, why? That's this week on In This Economy. A quick warning. This episode is about addiction and mental health challenges. Please listen with care. We recently received a message from Patrick, who has been navigating a really difficult situation.
Yeah, so I have a family member who is diagnosed with bipolar 2 disorder. And about 2.5 years ago now, came to us telling us that he had addiction to cocaine stimulants.
Patrick and his wife started doing research about how to navigate the mental health system so they could help support their family member.
And in our initial research, we realized the process through the public system is fraught with delays and lack of supports, lack of rehabilitative spaces.
Here's how it typically works when someone decides they're ready to go to rehab.
The first thing you generally have to do is get them into a detox center. And there's generally a 3 to 5 day wait to get into a detox center. Once in detox, that process could be anywhere from 4 to 13 days, depending on what their addictive substance is. And then the first hurdle comes after that, because publicly funded treatment centers need people to come right from detox, generally into the treatment center. But you could be looking at weeks to months wait. So they come out of detox with no supports and no real treatment other than sort of white knuckling it, going to local meetings for, AA, NA, whatever it is. And then if they're lucky, they won't use between detox and their opportunity to enter a treatment center. But if they do use, the process starts all over again. Whereas when you go to a private treatment facility, they just want you to detox in the facility, and then you're in.
Patrick and his wife were fortunate to have the resources to opt for a private facility. At least at first. Those private facilities cost a ton of money.
On the low end of the scale, $500 a day for a treatment center. And then on the upper end, and I'm not talking elite, but $1,500 a day for treatment. Most programs offer a 30-day treatment, but in our process, we learned that 30 days is not enough time to get any real progress in recovery. My family member is still in recovery, in and out of recovery. And fundamentally, we've come to the end of the line where we can afford to support financially the recovery process.
I'm Jordan Heath Rawlings. You're listening to In This Economy, where we help you understand the systems that create our money problems. In each episode, we hear from a listener who is facing a financial challenge. Then we talk to an expert who can explain the factors causing that problem and offer, if not perfect solutions, then at least a few ideas about things you can do or try to do, even in this economy. Unfortunately, Patrick's story is far from unique. Wait times for publicly funded mental health facilities and the resources associated with them are longer than they have ever been in most parts of Canada. Nadeem Esmail has been a senior fellow at the Fraser Institute since 2010, where he has co-authored a number of studies on the healthcare system in this country, including one last fall called Mental Health Care: How is Canada Doing? That study looks at the state of Canadian mental health care in comparison to other countries around the world. So that's where we started our conversation.
I think as we look internationally, what we find is the mental health care system largely reflects the performance of the general healthcare system. That is, we have limited access to services compared to other high-income countries with universal access healthcare, in spite of the fact that we put a larger proportion of our government spending into the mental health care system than other nations do. So, for example, we're 16th of 28 countries in psychiatrists, 15th in psychologists, we're 22nd of 28 in psychiatric care beds, and the median wait time for Canadians seeking mental health care is now up to 24.7 weeks, which is a remarkable delay for someone going through an issue.
Where do you see the biggest gaps in terms of our healthcare system versus some of our peer countries that would place ahead of us in the rankings? Where are we really falling short?
The issue in Canada is, as we see in so many discussions of healthcare, is access. We're certainly spending a lot of money on the healthcare system as a whole. In general terms, the Canadian healthcare system is one of the developed world's most expensive universal access healthcare systems. And as a share of government spending, Canadians are ranked fairly highly when it comes to how much money we're committing to mental health care. It's a little bit lower as a share of the total, but we're still a high spender overall. And yet what we find is these remarkably long wait times for access to psychiatric services, first to see a psychiatrist in the first instance, and then to receive the treatment that's identified and required. And that's in part a function, of course, of having very few psychiatrists relative to other countries. We just don't have the sort of resources one might expect, given all of the discussion we've had about how governments are going to commit to mental health care, put more money into mental health care, and all of the attention paid to the area.
Why is that? I mean, is it just we still haven't thrown enough money at it, or are we not getting value for our money, or are we just failing to attract talent?
Value for money in healthcare, or a lack of value for money in healthcare, rather, I think could be the Canadian motto for the healthcare system. It's really a raw deal for taxpayers who are paying for the healthcare because they're paying for a world-class healthcare system or a world-class universal access healthcare system. And yet patients are getting some of the worst access in the developed world when it comes to healthcare. And that appears to be just as true in mental health care as it is in general health care. Now, we have to be careful. The data are a little more limited when we're looking at mental health care systems internationally. But what we find broadly is that the Canadian approach is not dissimilar to those of any number of other nations in terms of what is covered and provided. But what we're doing is trying to deliver that approach with fewer doctors, with fewer hospital beds, with remarkably long wait times. The system simply isn't organized in a fashion or structured properly from a policy perspective in a fashion to get the value for the healthcare dollars we're putting in. And as a result, we're seeing Canadians with medium to high demands for mental health care in international comparisons receiving really not great access to the care that they need.
When you say really not great access, maybe you could put that in more concrete terms for somebody who's listening right now and who is thinking of going to their doctor and coming out and saying, I'm really struggling with my mental health or I'm struggling with addiction. What kind of timeline might they be looking at in order to get into treatment and then get what they need?
Between 2020 and 2022, on average, the wait from a general practitioner referral to see a specialist on an urgent basis, a psychiatrist, was about 2.6 weeks. Now that's up from 2 weeks in the early 2000s, so some deterioration. When we get to elective is when we really see those times stretching out. We're now up to 9.2 weeks to see a psychiatrist. That's the national median wait time between 20 and 22, whereas back in the early 2000s, we were down at 8 weeks. Then once you see the specialist, you of course need to move forward to treatment. And on average, that's taking about 15 and a half weeks. So in total, from general practitioner referral to treatment by a psychiatrist, the Canadian's waiting about 24.7 weeks now to receive that care. And that's up from 18.3 weeks in the early 2000s. We weren't doing really great in the early 2000s, but we're now nudging up to 6 months to get that medically necessary psychiatric care. That's a remarkable period of time to wait, especially knowing that we are committing to one of the developed world's most expensive universal access healthcare system.
Do we know what happened there? Because, to your point, over the past couple of decades, we've started talking more about mental health, and governments have at least stated that they're putting more money into mental health care. And yet you're telling me the wait times have gotten longer during that period. What's going on?
There's a lot of conversation. I think there's a lot of money. I don't think there's been a great deal of focus on improving the availability of services and innovative new approaches, not just having them in one small area or another, but really embracing innovation throughout the system and growing it. In order to deal with the mental health care gap in Canada, we're going to need to find ways of better using the resources we have. And we know internationally we're falling behind. We rank mid-pack to bottom in psychiatrists per 1,000 population and psychologists to 1,000 population, near the bottom in psychiatric care beds. No different from really general healthcare, where we find, again, very poor access to healthcare services in spite of high expenditures. Overall, I think the focus by governments too often is on how much money is being spent and not enough on how to get proper efficiency for the dollars that are going into the healthcare system to make sure that patients are getting value for the money that's being committed to it.
Are there things that our peer countries are doing in terms of finding those efficiencies or more unorthodox solutions that we aren't? What's out there that we should be looking at?
I think as we look internationally, again, the mental health care data and research is a little more in its infancy relative to general health care. This is more of, as much as we want to call it a newer area of focus, this really is a focus only over the last 10 to 15 years relative to general health care. We're finding, of course, as we look internationally, that there are areas that Canada does quite well innovatively in some aspects in some regions, but that doesn't seem to translate as broadly. The Organization for Economic Cooperation and Development did a massive omnibus study on access to mental health care and mental health care systems around the world. And it finds generally that many of these systems are really struggling with similar issues. What we do know, though, is that Canada doesn't stack up particularly well internationally in terms of the resources available. And that's a larger problem. We can be as innovative as we wish to be, but if we don't have the physicians, the psychiatrists, the psychologists to look after people, or even in Canada, the general practitioners to look after people, knowing that a large portion of mental health care in Canada is delivered in primary care settings, and that generally is the first point of contact for patients entering mental health care services. We also have one of the least accessible primary care systems in the developed world. We need to have more physicians on the ground. That's a long-term plan as well as a short-term plan. We need to make better use of what we have now, and we need to get more physicians trained, reduce the restrictions on training in Canada, create opportunities for licensing physicians from other countries more easily than we're doing now, while still respecting that we need to maintain standards and quality and certain requirements. I think there's any number of different approaches here, but the reality that we must face as Canadians is we just don't have the doctors and the hospital beds that other nations do. We actually have more mental health nurses than the average nation, but when it comes to the physicians themselves, we're short.
I'm Laura Palmer, host of Island Crime. Season 6, Sweethearts, is the story of 3 teenage girls who were all murdered in Victoria, Canada, within about 12 months.
So she was scared. Something out there scared her.
You've just created the playground where predators can really thrive.
She was a 16-year-old girl. She was a sweetheart.
Listen to Sweethearts at frequencypodcastnetwork.com or wherever you get podcasts.
Find your frequency.
When we cover the healthcare crisis on the other podcast that I host, The Big Story, one of the things we often find is that efficiency can vary wildly province to province. Is that the case in mental health care? And are there provinces that are doing, if not well, then better than the rest of them?
I think certainly as we look across the nation, the mental health care system overall is really not doing so great. And a large number of researchers have had considerable criticism for that program. Patients have been found to be subjected to significant delays in accessing physicians, specialists, and hospital services across the country. There's a lack of access to appropriate treatments. low rates of post-hospitalization follow-up, relatively poor access to care in rural areas, and a lack of practitioner-physician preparedness for dealing with mental health conditions and mental illness. And that's been found everywhere. As we look across the nation, though, some provinces are doing a little bit better when it comes to waiting times than others, certainly. Let's come back to that total wait time. The national median wait time is 24.7 weeks on average between 2020 and 2022. That's as low as 12.6 weeks in Saskatchewan, where services appear to be a little more accessible than in other places, but then goes well over 27.7 weeks in Alberta, 24 weeks in Ontario and Quebec, roughly. And then we go out to the Maritimes, where those wait times are going over 30 weeks, perhaps even as long as 48 or 50 weeks in Newfoundland and New Brunswick. So, yeah, and we see this in other healthcare research as well, where the struggles for access to services does appear to be a little bit worse in the Atlantic provinces than it is generally across the country. And generally speaking, we see fairly typical wait times in Ontario and Quebec, some provinces better than others. And even when we look at changes over time, some provinces have improved a little bit, Saskatchewan in particular. Manitoba has only deteriorated about 9% between the early 2000s and the early part of this decade. But when we look at larger deteriorations, again, let's look at New Brunswick, 35 weeks up now to 50, Nova Scotia, 20 to 34, Newfoundland, 21 to 48 now, much larger deterioration in other provinces. So certainly differences across the country, but I don't think anywhere in the country can we find a province that's necessarily doing what needs to be done here to ensure timely access to medically necessary care.
What does this mean for younger generations? And I ask that knowing that there's a lot of research during the pandemic that's revealed, the negative mental health impact that A, the pandemic, but B, also climate change and potentially social media is having on kids and teenagers now. And I would imagine that the need for mental health services is only growing. What happens to this system without action?
Certainly, the data agrees entirely with that view. Things are on the growth path as we look at the rates of depression and need for mental health care and the few statistics we have available. We can see that growth over that pandemic period. It's also an important reality to remember that mental illness and mental health concerns tend to have a higher prevalence among young adults and among the working young. It actually declines as you reach advanced ages. So this is fairly important for the Canadian population, which internationally tends to be quite young. If we don't do something about it, what will we see? We will see a continued lack of improvement. For example, perhaps in suicide rates. The Canadian suicide rate has been improving over time, but our rate of improvement has lagged that of the average developed nation with the universal access healthcare system. We also have higher than average rates of suicide among inpatients with a psychiatric disorder, which is something that should never happen. And yet we're not a leading nation. This is really a healthcare system that is not improving at the pace of others, that is not able to deal with what it's faced with now. And as you point out quite rightly, this is a population whose struggles appear to be increasing over time, in part due to a number of important external factors that we can identify. And we're going to need to sort this out. I don't know that any government has really come out with a great solution as yet, or really a great plan. I think we have some good attention being paid to the area, with different ministries now being refocused on the area, with a lot of conversation about it. But that conversation is still back at the we want to do something and here's lots of money stage, not at the here's how we're going to deal with the fact that we don't have as many doctors as other nations stage. And I think that's where the planning needs to get to, is real action plans, not just platitudes and money.
Given the current situation, what do you recommend? And I realize you may not be a particular expert in this area, but what do you recommend people do if they don't have enough money to simply, pay out of pocket for more private services? How do they navigate what is available out there? What would you recommend?
I think as it comes even to general healthcare, it's really about ensuring that you're an advocate for yourself as a patient. You're seeking out those resources that are available to you and advocating on your own behalf. Certainly, we know the primary care system is difficult to access in Canada, but there are avenues to get to it. And the Canadian model is not, in terms of broad coverage, dissimilar to that of a number of other models around the developed world. In fact, our general coverage would be pretty similar to the programs in nations like Belgium or Japan or Luxembourg or Norway or Switzerland. I mean, Canada's not an outlier. Canada is an outlier in accessibility, but certainly in terms of the broad approach, we're not an outlier. And in terms of spending, we're not low. The resources are out there, they are available. Certainly there are challenges accessing them, but there is really no path other than, I think, to be an advocate and to seek out that care and to try different avenues, to try the doctor, to try the nurse practitioner. Canadians are more likely than residents of other nations to go to emergency for mental health care needs, possibly a reality from limited access to primary care. But again, there are avenues out there. It is a program that is not dissimilar to those in the other parts of the developed world. We just don't have the access that you would expect for the money we spend.
In the bigger picture, and I do realize we could do an entire episode on this alone, if the problem is simply we don't have the resources, how do we get them? Where do we go to get psychiatrists and family care doctors that can actually address mental health? And are we planning on doing that?
The physician to population ratio problem is an old story. It begins in the early 1990s when there was a concern there would be too many doctors by the early 2000s.
Really?
It's remarkable. Medical training in Canada at the time was pared back in order to maintain the physician to population ratio that was prevalent at that time. It's a governmental success story in the physician to population ratio that was prevalent at the time in 1993 was about 2.1 physicians per thousand population. And that was maintained throughout the period, in part by training not enough physicians to maintain it and then allowing international medical graduates to fill that gap. Unfortunately, what happens over this time is we find Canada moves from, in the 1970s, 1980s, being one of the highest physician to population ratios in the developed world, now to the early 2000s onwards, being one of the lowest physician to population ratios in the developed world. Part of the answer has to be taking those restrictions off medical training in Canada, allowing qualified Canadian students who are capable of becoming physicians, who are capable of passing exams, to do so, rather than limiting their entry, making it as hyper-competitive as it is now, and forcing so many Canadian students abroad for medical training where they are now international graduates who have difficulty returning or may find a home in another country instead of coming back to Canada to care for people in their own home. I think there are also some things we can do on the international medical graduate side. Certainly, there would be some interesting avenues that might include mutual recognition of American or European physician certifications rather than asking them to recertify as Canadian doctors, simply accepting the European certification. And I think there's some important pathways we can research and look at for international medical graduates from abroad, which I know is being done, and there's a lot of talk about it, in part in response to this misstep in limiting the number of Canadians who can be trained as physicians.
I didn't know that context. That's a new one to me, and I thought I'd heard it all about how we screwed ourselves with the medical system.
It's a remarkable piece of history, and it comes from a belief at the time that if you had too many physicians, you would get what was called supplier-induced demand. That physicians would create demand for their own services in order to maintain their incomes. Now, that has largely been debunked over time, but the consequence for Canadians in terms of having so few physicians now is very real, and it clearly has an impact on their access to primary care services, and then further into specialist care. There's a little tweak on specialist care on the surgical side, and that is not only do we have long waiting lists for medically necessary services and a lack of access to them, we also have unemployed or underemployed surgeons in Canada who can't find appointments at hospitals so that they can practice their trade. The level of dysfunction in the Canadian healthcare system is remarkably high, which goes towards explaining how it can be one of the developed world's most expensive and simultaneously one of the developed world's least accessible universal access healthcare systems. And I think when it comes to mental health care, the sad reality is the mental health care system has not escaped that fundamental reality of healthcare generally.
Last question then. You've mentioned a few times that there are things we could be doing that people are actually looking at, like international certification, that ministries in various provinces have started to focus on mental health. Are you optimistic we are starting to get serious about this? What do you see, not only in the data, but in terms of what you hear when you talk to people in the field about how realistic we're being in terms of fixing this?
I think the drive is there to fix it. And certainly I don't think anyone's out there saying we don't want to. We're seeing more and more as well, physicians and medical practitioners getting burnt out, getting frustrated with their inability to look after their own patients. That's very real in the healthcare system.
Sure.
I think when it comes to governments, though, I have to be a little bit pessimistic. And I have to be pessimistic because if I look at what's happening and I look at what governments are doing in response, we have a healthcare system that is continuing to fail Canadians. It is failing them on a day-to-day basis in terms of delays in access and services, in terms of not being able to get them the right service at the right time for their need, and ultimately leaving them with both lost time and productivity while they're waiting and potentially worse outcomes from what they were ailing from because we never got to it the way we were supposed to or the way we could have, knowing that medical technology and medical knowledge would have allowed us to treat that individual. It's remarkable that I think it was in some research done in the United States, it's been reported that we are capable with modern medical technology and knowledge of dealing with most mental health conditions, if only we can get the individual to the right treatment in the right period of time. And that's where the failure is. It's not that we don't know how to solve the problem. It's that we're not getting the treatment to the patient in time. And yet in all of this, what we see from governments is yet another multi-billion-dollar announcement from Ottawa for the provinces, yet more provinces saying we're going to spend more money and maybe shuffle some bureaucratic deck chairs. No one's stopping and stepping back and saying, well, hang on, this system is failing. And it's failing in spite of a world-class level of expenditure. More money is not the problem. What we need to do is actually fix the healthcare system itself. We need to understand why it's inefficient and attack those problems. For general healthcare, we know the solutions: cost sharing, activity-based funding, private competition and delivery, an alternative to the governmental scheme. Those are common policies in 100% of the developed world's top performing universal access healthcare system. Everywhere we find a high performing healthcare system, we find those policies. Yet in Canada, we won't go down that path for political reasons and otherwise, and reasons including Ottawa's wishes and how they're tied to the transfers. In mental health care, I think it's still in its infancy, but I feel the debate is very much in the same place. It's a lot of platitudes and a lot of money without any real concrete action to admit the system isn't working today, we need to do something about it, and then to embrace approaches that are different from what we're doing now in the search of a better answer for Canadians.
Nadeem Esmail, a senior fellow at the Fraser Institute. Thanks to Nadeem for sharing his insight with us. And thanks to Patrick for sharing a really tough story that inspired this episode. And we send all our best to you and your family. If you have a money problem, we do want to hear from you. You can email us, as always, at hello@itepod.ca. You can also call us and just talk to us. Leave us a voicemail at 416-935-5935. We don't need you to give us your real name. We do need your real numbers, the numbers around your financial problem, and especially the phone number, so we can get back in touch with you if we want to take on your episode suggestion. If you like this show, if you want more of this show, you need to share it with your friends and tell your friends to listen and share their money problems as well. We are only as good as the things we can help you with. So give us whatever you've got, and you can also like and rate and review and follow and all of those things, whatever your favorite podcast app allows you to do. And that will help our show reach more people. I'm your host and executive producer, Jordan Heath Rawlings. This episode was written and produced by Marshall Whitsitt, Allison Broverman, and Stephanie Phillips. The sound design was done by Christy Chan. Mary Jubrin is our digital editor. Diana Kay is our manager of business development. Together, that makes us the Frequency Podcast Network, and we are, as you may know, a division of Rogers. Thanks again for listening, and we'll talk next week on In This Economy.
My name is John Cullen, and I want to tell you a story. It's a story about a scandal, broken relationships, gossip, rumors, money, corporate rivalry, and curling. It's the story of Broomgate, how a single broom, yes, a broom, turned friends into foes and almost killed the 500-year-old sport of curling.
It was a year I'd like to forget.
Broomgate, available now.